Hello, we're going to be talking about abdominal wall blocks and blocks of the back with Dr. Jonathan Womack. Could you please let us know about the nerves that you target while doing these different abdominal blocks?
Okay, so this is the most simple neuroanatomy that we've got in the body, basically. The thoracic nerves are all three-branched nerves, so they start in the back and come around to the front, and on the way they give off three branches. So there's a posterior branch, and that's going to supply cutaneous innervation to skin from the midclavicular line to the midline on the back. There's a lateral branch which is going to come out in the midclavicular line, and that's going to supply cutaneous innervation from the anterior to posterior midclavicular lines. And then there's an anterior branch which comes out anteriorly, just parasternally in the chest and through the rectus in the abdomen. One thing that people often forget is that the whole of the trunk is thoracically innervated. So remember that your thoracic spine ends midway down your back, but your pubis is essentially T12. So the nerves angulate downwards, much like your bucket handle ribs. So I think that is important to remember. So the chest and the abdomen are essentially the same things here.
Okay, so considering the tap block, what are the differences between kind of the posterior lateral and the subcostal blocks?
Okay, so I'll take one quick step back. So these nerves that we've been talking about generally follow. They come out of the back, and once they get to the point where they give off the lateral branches, they run in a neurovascular plane, and the neurovascular plane is between the lateral muscles. So in the chest, these are your intercostal muscles, and in the abdomen, these are your lateral abdominal muscles. So in the abdomen, if you can see on the slide below, we've got the external oblique, the internal oblique, and transverse abdominalis, and the neurovascular plane is between the second deepest and the third deepest, so internal oblique and transverse abdominalis. So a traditional tap, well, the first described ultrasound-guided tap block, whether it's the original tap block or not is slightly disputed, is between these three, well, the second and the internal oblique and the transverse abdominalis in roughly the mid-clavicular line. Mid-axillary line. Now, so that's a traditional tap block. Now, that's moderately superficial. It's quite easy anatomy, and so it was very popular because people could do it. It was something that you could have a bash at with little experience. The issue is that remember that these lateral branches come out in the mid-clavicular line. Mm-hmm. The problem with the lateral tap block is you get a nice image often before that, more anterior to that. So the traditional tap block may actually just get the anterior branches. Mm-hmm. So, a small segment here in the center of the abdomen. The subcostal tap block, that's a bit of a variation. The idea is that with a traditional tap block, you consistently get T10 to T12 rami, possibly the lateral, probably not, but the anterior branches. So that's a subumbilical cutaneous block, essentially. The tap block, the subcostal tap block is aiming to get some higher nerves. So traditionally what you'd do is you'd infiltrate in that same plane, but subcostally, so more anterior. And if you go in a full, we'll see later the scanning, but if you infiltrate along that plane, you're going to get up to T7. So it's much better for potentially an upper abdominal incision or port sites for lap chole, something like that. So certainly you get a much higher dermatomal block than you would with the subumbilical. And the sort of more posterior tap blocks, or moving on to QL blocks, etc., they're a variation of the ultrasound-guided tap block to try and be more like the originally described landmark tap blocks. So these are more posterior, and the idea is that you're more likely to get the lateral branches. Now, personally think that talk of paravertebral spread here is ambitious and unlikely, but certainly you're more likely to get lateral branches. I think the cadaveric evidence, although that's always a bit dodgy to go on, but would be that you still get subumbilical or maybe a little bit higher up, but certainly not the same T7 block that you would with a subcostal tap.
So what's the best volume to inject, and what surgeries can I use this for?
So, QL block, traditional tap block, subumbilical incision. So fan steel is a perfect one. Inguinal hernia repair, anything in that area there. The subcostal tap block, the addition, if you add that, you're going to get more abdominal wall coverage. So anything that covers up to T7. Remember that with all of these, you're not going to get the visceral supply. So this is purely a muscular and cutaneous block. You also immobilize the muscles of the abdomen, so it might well be that actually the significant analgesic effect of these is to mean that you don't use abdominal muscles for coughing. So perhaps that's the analgesic effect is essentially that you don't you can cough more comfortably. All of these I would suggest are volume blocks. So what volume can you inject? I would look to be injecting 20 to 30 mils on either side. Remember, you have to do it bilaterally, and it depends on the weight of the patient. So use a higher concentration and higher volume as you can, but aiming to do 20 or 30 mils for each injection.
So moving on to rectus sheath blocks, what makes these different from the tap blocks?
So rectus sheath is explicitly an anterior branch block. So as the anterior branches come through that neurovascular plane, they then settle along the posterior rectus sheath and go through the muscle to supply the skin. So rectus sheath blocks are really popular for midline incisions. So this is where they're really useful. They're pretty easy, so it's quite superficial. The posterior rectus sheath is, especially if you must remember to go above the umbilicus, and I'll talk about that when scanning. But it's pretty thick, so it gives you something that it's difficult to go too deep. And the advantage is that because it's continuous, there's nothing separating the dermatomal layers. You can get good corticephalad spread. So you can see on the slide it's saying that you get that essentially covering the whole of the midline. I think that's probably ambitious, but I've never found any cutaneous studies in volunteers. But certainly upper midline, definitely, if you inject again on either side. So the utility of the rectus sheath is it's easy and it's great for an upper midline incision, and it's good for an emergency laparotomy when you wouldn't otherwise be able to put an epidural.
Perfect. So moving on to the back, one of the most popular blocks is the ESP, the erector spinae blocks. Why do you think it's gained such popularity?
Very interesting question. So I think, why has it gained popularity? So for the last 10 years, people have been trying to find a trunk block that utilizes paravertebral spread, but is technically easier than a paravertebral block. And I think probably the erector spinae is the best of the lot. So it's the one that posterior quadratus, lumborum box, serratus plane, all of these, and to some extent tap blocks as well. So it is technically easier than doing a paravertebral, and there is an inherent safety in the fact that you find the transverse process and you're aiming towards that. So there's a safety margin because you've got quite a long way to go before you damage anything. So I think it's technical ease and the fact that it's an abdominal and thoracic block.
How does it actually work, though?
Good question. So I would say that there's two main mechanisms. If you look at this is one of the cadaveric studies. So I think this was from anesthesia. I believe it is Yang et al. There is extensive spread of local anaesthetic up and down the erector spinae muscles. Now, that is not in itself that useful unless you're trying to block the posterior rami. So with that spread, you would get a really good block on the back, but in the mid-clavicular line. It's great for middle back surgery, but it's not that great for abdominal or thoracic surgery. You can see that there is spread deeper to the to deeper layers. So there's two mechanisms, I think, that how it might work. One is that lateral spread along essentially the serratus plane, and that would block the lateral cutaneous nerves, but also spread through into the essentially into the paravertebral space. If you look at the volunteer studies, and there is and the cadaveric studies, both mechanisms can be observed. So there is a slight unreliability to it in the sense that anterior innervation is difficult to catch and maybe not quite as dense. So it might be that some of the effect is by lateral spread to the lateral cutaneous, and some of it is by spread into the paravertebral space. No one really knows, but it does seem to work.
Brilliant. Thank you very much.
Pleasure.